Okay, shall we start now?
Yes, please.
Okay. بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. I'm Dr. Ammar Babtain, consultant adult hematology in Al-Hada Military Hospital. Good evening, everyone, and welcome to our virtual webinar tonight that is organized by the Saudi Society of Blood Disorder. I would like to thank the Novartis company for sponsoring to this activity, and it's my pleasure to be with you today as a moderator of this activity with three outstanding speakers. And as you know, our talk today will be about the chronic myeloid leukemia. And over the last decade, the chronic myeloid leukemia is evolving on the management paradigm. And we are standing now in the era of treatment-free remission. So without any delay, I will start to introduce the first speaker, who is a well-known big figure in hematology, and I'm so honored to introduce him. So Dr. Dennis Kim, he is a physician, clinical investigator in medical oncology and hematology at Prince Margaret Hospital, Toronto in Canada. He is an associate professor at Faculty of Medicine at University of Toronto. He is an associate faculty of member at Institute of Medical Science at University of Toronto. Dr. Dennis Kim is a member of Canadian Hematology Society. He is a member of Canadian and of Blood and Bone Marrow Transplantation Group. He is an international member at American Society of Hematology. He is a member of Korean Society of Blood and Marrow Transplantation. He is a member in Korean Society of Hematology, and he is an associate member of American Association of Cancer Research. Dr. Kim, he has more than 200 publications, and he has been an investigator for many reviews. He has contributed in many book chapters in hematology. I'm so honored to introduce you, Dr. Kim, and the stage for you.
Thank you. So I will share my slide for my presentation. So can you see my slide?
Yes.
Good, thank you. So I'm going to talk about CML Horizon, the present and the future. This is the title of my talk today. And this is my disclosure. And this is the topic for today. So I'm going to talk about my first part will be about the updated CML guideline, including the ELN recommendation 2020. So as you can see, we are very familiar with the ELN recommendation 2013. In recommendation 2013, they have three categories of response: optimal, warning, and failure. And you are very familiar with these molecular response scales. You see here international scale and log scale. So from the time of diagnosis, if there's a reduction of transcript level by 1 log reduction, it is equivalent to 10%, which is our primary molecular milestone to be achieved in first 3 months. It is the same with 10%. And 6 months, we want our patient to achieve less than 1%. And in 12 months, in our patient to achieve less than 0.1%, then we call it is optimal. In that case, we don't need to switch the current treatment. However, if a patient fails to achieve a certain milestone, such as fail to achieve less than 10% at 6 months, we call it failure, which means that we have to switch the medication. And in 12 months, if a patient fails to achieve less than 1%, then we call it failure. In that case, we have to switch the medication. However, in the context of TFR, which will require to achieve less than more than MR4 or 4 log reduction or 0.01%, in that case, what will be the optimal goal of their CML therapy? Maybe probably they have to achieve MR4 first before considering the TFR attempt, which require TKI discontinuation. So there's some change in the ELN 2020. Now, this is a ELN recommendation 2020. You see here almost the same. However, there is some difference here. First one is that the you see here, the 3 months milestone, if they fail to achieve less than 10%, they call it failure. Before that, they just call it warning. However, now they clearly call it, if it is confirmed, it is a failure. Another thing is that you see here in the subline here, for the patient aiming for the TFR, if the optimal response is not a MMR anymore or a 3-log reduction, it is MR4 or 0.01%. We want our patient to achieve more than MR4 log reduction. Another change is that you see here, change of the treatment may be considered if MMR is not reached by 3 to 4 years, because based on the ELN 2013, there is a concern. Now, in terms of the optimal response, then MMR, the achievement of MMR in first 12 months is optimal criteria. In that case, if a patient failed to achieve a 3-log reduction in first 12 months, should we switch the treatment right away or should we wait? If we wait, then how long do we have to wait? The answer is provided here. A change of treatment may be considered if MMR is not reached by 3 to 4 years. Just I want to compare the ELN 2013 and ELN 2020 in terms of the optimal response. As you can see here, this is ELN 2013. Optimal 1-log reduction in 3 months, 2-log reduction in 6 months, and 12 months 3-log reduction, and 6 and 12 months of failure. And this is ELN 2020. You see here, the difference between the ELN 2013 and 2020, ELN 2020 is here. For 3 months milestone, the failure, so the failure means that if a patient fails to achieve less than 10% in 3 and 6 months, it is a failure. And another thing is that optimal response. So they want our patient to achieve optimal more than MR for any time if TFR is their goal of their CML treatment. That is the difference between ELN 13 and ELN 2020 in terms of optimal response criteria. Let's move on to the other recommendation that has been published last year, GMEMA criteria, which is from the Italian group. And you see here, they are now looking for, when TFR is the primary goal, what will be the optimal response criteria? Now you see here, you get the sense of how they are thinking of incorporating the TFR concept in their case management of their CML. You see here, in 24 months, they want patient to achieve more than MR4, and they really want their patient to achieve MR4 or deeper response in first 2 years, if TFR is their goal of their CML therapy. So now you can see here, the TFR concept has been already applied into our clinical practice. Now, in case of me, when I see newly diagnosed CML patient, I start discussing about this TFR concept in first 1 or 2 visits of their clinic. And I use this concept when we make a decision for their TKI drug selection. This is the treatment option listed in ELN 2020, frontline therapy and second-line therapy, as well as a treatment beyond the second line. Beyond the second line, allo transplant, ponatinib, or some experimental drug is available, such as asciminib, but we don't have that many of choice right now. Let's move on to the second line setting. So in case of the second line, as you can see here, they mentioned in the ELN 2020 recommendation saying that the definition of response or milestone to second-line treatment should be the same as the first-line therapy. You might be curious why they are saying that. Let me explain this way. It is a ELN 2013, and in ELN 2013, this is the definition of response for first line, and this is the definition for second line. They have a separate response criteria, which gives a lot of confusion. And for example, one of the examples here, you can see here, for frontline setting, MMR is a goal of their CML treatment to be achieved in first 12 months in the setting of first line. However, you see here, MR2 or 2-log reduction in first 12 months is the goal of a second line. Now you are treating the same CML patient, but why they have a different definition of response? That is the reason that in the ELN 2020, they just make it uniform. You see here, first line and second line, they use the same optimal criteria between the first and second line. 1 log reduction in 3 months, 2 log reduction in 6 months, and the 3 log reduction in 12 months. They use the same optimal response criteria between first and second line in ELN 2020. Let's move on to the third line setting. Beyond the second line, they are saying that definition of acceptable response to third line, fourth line, and fifth line cannot be formalized. However, BCR transcript level, only 2 log reduction or 1% or CCYR are not enough for optimal survival. So you may need a little bit of a different parameter to evaluate a certain treatment that can be used for third line or beyond. So this is my summary slide for my part 1. So there is a new clinical recommendation guideline in CML practice, and now we accept the MR4 as a definition for optimal response over their goal of CML therapy when TFR is considered for their goal of CML treatment. And they would like to remove a different parameter between the first line and second line, and they have now uniform milestone for optimal response between the first line and the second line. Beyond the second line, still probably the use of molecular response below 1%, that is not enough for guaranteeing optimal long-term outcome in our CML patient. So let's move on to a TFR. So now in ELN 2020 recommendation, they mentioned about some TFR requirement. So now you see here, they only recommend the TFR attempt in CML patient in first chronic phase and motivated person. And you should have your quantitative PCR test with the rapid turnaround time, et cetera, et cetera. And they mentioned about the minimum criteria versus the optimal criteria. Minimum criteria of TKI treatment duration more than 5 years, or 4 years with the second generation, or DMR duration more than 2 years. That is a kind of minimum criteria. And they also provide an optimal criteria. So it's a little bit confusing. Let me explain you in this way. Now, this is the recommendation from Tim Hughes and NCCN and ESMO, GMEMA, and ELN. You see here, just pay attention to this duration of TKI therapy. Some recommend 8 years, some recommend 5 years, some recommend 4 years. It is all around the map. And you see here, in terms of the duration of DMR, 2 years, 1 year, or sometimes it's a little bit different. So my idea for my research project is that probably we need some optimal cutoff for the duration of imaging treatment or MR4 response, which can provide maximize the probability of TFR success with a minimum duration of a certain treatment. So the main idea is that when you try to continue to treat the patient with a longer period of time, you can maximize their TFR success. However, from certain time point, that chance can be maybe plateaued. Then maybe you might be able to treat the patient up to this period of time. And then you can try to recommend your patient to stop the TKI therapy. Then you will have a really good success, and your patient doesn't need to be on unnecessary treatment. If they can stop the treatment earlier, then they will be better, right? So that's the reason that we did a kind of research study. And we also look at that one additional year of imatinib treatment or MR4 treatment duration seems to decrease the risk of TFR failure by roughly around 13%. Once you convert it to a TFR rate, then that rate will be roughly around 3% per year. So one additional year can increase your chance of TFR by 3%. And then we did a kind of statistical analysis. Now you see here, so now we adopted the recursive partitioning method. It is a little bit more complicated part. However, I'll just explain you one by one here. This is the probability of their TFR. For example, 6 years, then you will see their TFR rate when they get treated more than 6 years. It's roughly around 60%. versus if they get treated less than 6 years, then their TFR rate is roughly around 38%. And then this is the proportion of the patient. So the number of the patient treated longer than the 6 years versus less than 6 years. And this is their positive predictive value and negative predictive value plot. So the meaning is that now when they positive predictive value means that when they get treated longer than 6 years, what will be their chance of having a TFR success? Then you can calculate that. That is roughly 68%. And negative predictive value means that if they are less than 6 years of TKI treatment, what will be their failure rate of TFR? That is roughly 61%. So based on the 6-year time point, you will see that more than 70% or 60% of the patient, we can predict it properly. And this is the p-value. P-value, this is minus log 10 p-value. This line is roughly p-value of 0.01. And the higher, then the deeper p-value, which means that this group of the patient is going to become this value is going to become very significant. So based on this, we made a decision that the optimal cutoff value for imatinib treatment duration was 6 years versus MR for duration of 4.5 years. I know it's a little bit complicated, but based on this is our conclusion. So taking into consideration maybe 6 years of total treatment duration of imatinib therapy and 4.5 years of MR for response duration seems to be the optimal cutoff to maximize the probability of TFR success based on the Canadian TKI discontinuation trial. So my next topic is about the ASSEMBLE trial, but I think that you are very familiar with this data, so I will try to make it shorten as much as I can. So as you see here, beyond the second line, as you see here, BCR-ABL transcription level just 1% is not enough to guarantee their optimal survival. But that is the reason that in this ASSEMBLE study, which is a third-line trial, they use different primary endpoint. Rather than the CCYR, they use MMR as their primary endpoint to evaluate that. So this is the structure of BCR-ABL fusion protein. And now you see here, this is ATP binding site. And in this site, maybe bosutinib, nilotinib, imatinib, dasatinib, and ponatinib can bind. However, asciminib, they bind in a different site called the mystory pocket here. So it has a different target for inhibition of ABL1 protein, and it has very less off-target effect, which means that it may not have that much of off-target side effects, such as pleural effusion with the dasatinib or cardiovascular effect with the nilotinib or the diarrhea with the bosutinib. It doesn't have that kind of adverse event. So as you see here, primary endpoint was MMR at 6 months, and this is the primary endpoint. 25% of MMR with the asciminib versus 13% of MMR at 6 months with the bosutinib. So definitely asciminib showed a better efficacy, roughly around 2-fold higher efficacy in efficacy in comparison to bosutinib. It showed that. And they also look at the conventional response parameter, which is CCYR, in the setting of third-line therapy. And again, 40% versus 24%. And as you are aware of, the third-line bosutinib trial showed roughly around 25% of CCYR rate. So I think that this number is quite equivalent to third-line phase 2 bosutinib data. And now you see here, asciminib showed a higher number of CCYR rate at 6 months. I want you to pay attention to this. So this is the overview of adverse event. So you pay attention to the number of the cases developing adverse event leading to discontinuation of the drug. In asciminib group, only 5.8%, they stopped the asciminib due to adverse event. However, in case of bosutinib, 21% stop their medication due to adverse event, which means that in terms of the off-target side effect or adverse event, asciminib seems to be much better in comparison to bosutinib, and that might be the reason that you can continue your treatment as a third-line option without having any kind of issue, and then you can improve your efficacy rate. Think about it. This patient is the patient who is being treated with this treatment as a third-line therapy. They already failed the 2 lines of TKI therapy, and they might be contraindicated for the other 2 TKI therapy for other comorbidity issues. They may have a diabetes, they may have a cardiovascular event, they may have a lung disease, and because of that, they are not indicated for other option of TKI therapy. In that case, probably their third-line therapy drug will be their last chance to eradicate their CML. And in terms of that, the side effect profile is extremely important in terms of maintaining their current treatment in the setting of third-line therapy. And this is all AEs. You see here, as expected, a little bit of higher instance of diarrhea with bosutinib and GI, as well as liver enzyme elevation. However, in terms of the neutropenia, asciminib doesn't show any higher number of neutropenia, a little bit of higher number of thrombocytopenia, but that was not translated into a higher number of discontinuation of asciminib. So this is a summary of ASSEMBLE trial. Asciminib demonstrated statistically significant and clinically meaningful superior efficacy in the setting of third-line therapy. So my expectation is that in next 5 to 10 years, you will start to use this compound in your CML practice in a different scenario, like not only the third-line setting, maybe a front line, or even in combination. You might be able to think about to incorporate this compound in combination with other TKI to treat your CML patient. So that is coming in our near future in our clinical practice. So my last part of my talk is about the somatic mutation beyond the BCR-ABL genetic event and how to implement it into a precision medicine into your clinical practice. So I'm just passing by. I think that so my initial, I published this paper in 2017 about the mutation profile in CML patient. So in 100 CML patients, we sequenced their T-cell sample, diagnostic sample, and follow-up sample. Follow-up sample is the sample taken at around 6 to 12 months after their TKI therapy started. And roughly 37 patients, I will say 1/3 of your CML patients, they carry certain mutation during their course of TKI therapy. And now you see here, there's a 3 pattern. Once you compare their mutation profile from diagnosis to follow-up, there's a 3 pattern. And this is their clinical response. So the light blue means that they are responding to TKI therapy very, very well, versus the orange one means that they are resistant to TKI therapy, versus the brown one, they are progressing to advanced disease. So based on this, we divide them into 3 major patterns. So as you can see here, pattern 1, please pay attention to this. They have a really good response to TKI therapy. And you see here, some mutation was detected at the time of initial diagnosis. However, they are responding to TKI therapy very well. There is no change in their mutation profile. This is pattern 1. Pattern 2 means that you see here, they are the group of the patient very resistant to TKI therapy or even progressed to advanced disease. And there's a new mutation comes up. That mutation include the ABL1 kinase domain or ZBP1 or TP53. So that kind of mutation was acquired during their course of TKI therapy, and that correlated with their adverse outcome following the TKI therapy. And pattern 3 is that they have a certain mutation at the time of initial diagnosis, but while they are getting a TKI therapy, you see here, actually that number has gone down. And you see here all the profile of the mutation include the ASXL1 or LUNGS1, etc., etc. And now you see here, their clinical response to TKI therapy is very diverse. Some group, they responded very well. Some group, they are resistant. Some group, they progressed due to advanced disease. So based on this, we compared their molecular responses, CCYR and MMR, according to the presence of some mutation in an epigenetic pathway. And now you see here, if they have a certain mutation in an epigenetic pathway at the time of initial diagnosis, their response was not that much great. And in our population, 90% of the patients get treated with the imatinib, and only 10% of the patients get treated with the second generation TKI. So I will say that this illustrates the adverse impact of epigenetic pathway mutation on their outcome to imatinib. But we were curious what is going to happen when you treat them with the second generation TKI. And then there's a data coming from the Hammersmith Hospital. They compared the outcome between the imatinib treated group. You can see here, if they have a somatic mutation, they have a poor outcome because of that epigenetic pathway mutation. However, when they get treated with the second generation TKI, mainly with the nilotinib, now you see here, their adverse outcome has become overcome by using the second generation TKI. Rate of MMR, event-free survival, progression-free survival, and CML-related survival all become neutralized by using the second generation TKI. And also, this is another meta-analysis data. Now you see here, we look at the more than 11 papers published, analyzed the impact of mutation profile in CML area, and this is a summary. Now you see here, there are several mutation or genetic events that can be commonly detected in CML, such as a LUNGS1 mutation and the ECAROS gene deletion, as well as ASXL1. ASXL1 is detected roughly around, you see here, 10% of patient. However, once you look at the ECAROS gene deletion, at the time of initial diagnosis, it is only detected in 6% of the patient. But in case who progressed to accelerated phase of blastic crisis, the number has gone up to 16%. The same for LUNGS1 mutation. Only 2.6% of the patient have a LUNGS1 mutation, but at the time of accelerated phase of blastic crisis, roughly 18% of the patient, they have a LUNGS1 mutation at the time of progression. So I will say that LUNGS1 or ECAROS gene or even the TP53 has a kind of potential to identify the case who is in high risk for transformation to advanced disease. Another part that we can use this NGS technology is maybe for the detection of ABL1 kinase domain mutation. So this is the spectrum of ABL1 kinase domain mutation. And this, I'll just pass this one. This is the method to detect, the technology to detect ABL1 kinase domain mutation. You see here, you can use the Sanger sequencing, DHPLC, allele-specific PCR, mass spectrophotometry, et cetera. And Sanger sequencing is a kind of standard method. But the problem of Sanger sequencing is that the sensitivity level or limit of detection is only roughly around 20%. You cannot detect very minor clone based on the Sanger sequencing. So there's a lot of room to improve it. NGS, based on the NGS, you can detect up to like a 1% of case, but our current NGS, if you go ahead with maybe 200x of a sequencing depth, then maybe the limit of detection will be around 5 to 10%. If you can reach up to 1,000x, then you might be able to have a limit of detection of around 0.1% or 0.2%. So there's some way that you can improve by using the NGS for ABL1 kinase domain mutation. So this is the limitation of current NGS technology. Based on that inherited sequencing error that can occur 1 out of 100 or 1,000 nucleotides, you need to improve. You need to improve your sequencing detection method by using the duplex sequencing or barcoded sequencing. So I'm just passing this one. So you can see that by using the NGS, you can improve your detection rate up to 50% from the 25%. So this is our current algorithm. I'm now currently working on this one as a part of research project. So using the panel, we can detect the ECARS gene deletion, LUNGS1 mutation, TP53 in the beginning of the diagnosis of CML. And based on the ABL1 mutation, maybe it can guide our frontline TKI treatment drug. And if they have some epigenetic pathway mutation detected, then I will go ahead with the second generation over the imatinib treatment. So my last slide is this one. I have one more, but we have a SMIP technology, which is barcoded error character sequencing. It can detect up to 10 to the -3. And it covers most of the important genes such as ABL1 and ECARS gene and the ASXL1, LUNGS1 and TP53. And we are now running it as a part of a research project at PMH in collaboration with the OICR, Ontario Institute for Cancer Research. And now I'm working on this research project. So this is my last slide. CMA Horizon, we have a lot of changes and improvement in terms of the guideline. And asciminib is on horizon in the clinical setting of a third-line therapy. And probably you will hear some other new data for frontline use of asciminib or the TFR data, or maybe you might be able to think about the combination strategy of asciminib with the other TKI. And precision medicine use, it is coming, and stay tuned. And remaining issue is that which gene to be included, or which platform, or do we need a long-term follow-up, et cetera, It is not answered yet, but we are now working on to generate that kind of data. Thank you for your thank you for your listening. So I'll be happy to take a question at the end of the other two speakers' talk. Thank you.
Thank you, Dr. Kim, for this wonderful talk. Excellent review of CML treatment 2021. And we'll remind the audience to put their question in the Q&A, and question and answer will be at the end of this meeting. So we'll move to the second speaker, who is Dr. Abdullah Suidan. He is a consultant molecular and genetic at King Faisal Specialist Hospital, Riyadh. Dr. Suidan, he finished his hematopathology fellowship at 2018 at University of Texas. Dr. Suidan, he did his molecular genetic pathology fellowship at Pittsburgh Medical Center in 2019. Dr. Suidan has many publications, and he will talk today about the CML profile by next generation sequencing. Dr. Suidan, welcome, and floor is yours now.
Yeah, thank you so much for having me. I would like to start by thanking the organizers and the attendants. And it's difficult to give this brief talk, especially after Dr. Kim. He gave very nice introduction about molecular CML and mutational profiling. My talk will be brief, just about what we do in molecular, and a brief introduction to CML, and something about mutational profiling and NGS technology. First, I would like to say that in CML and even in other, we need to have integrated approach, multidisciplinary approach. So it's not just the diagnosis, clinical, not just the morphology. Now we have more. We have the immunophenotyping, we have the karyotype by cytogenetics, and we have the FISH analysis. We have the molecular technique, we have the BCR, NGS, and other more sensitive techniques. So we are getting more and more data that need to be integrated for optimal patient care. And when we look at major indications for molecular testing, so we use molecular testing at time of diagnosis, and sometimes we use it for classification, for prognosis, for monitoring, detecting like MRD, and for targeted therapy. And sometimes we use molecular for cryptic analysis if it cannot detect by karyotype or something. In terms of NGS, I usually use this slide as a brief introduction to next generation sequencing. It's also known as massive parallel sequencing. Basically, we read the nucleotide. As you can see here, there's nucleotide sequence at the end of the page. This gene is KRAS, and we are trying to see if there is any mutation, any change at nucleotide level. Compared to Sanger sequencing, this is a picture of Sanger sequences in the right side. This is just a read of one sequence. On the other hand, massive parallel sequence, we sequence the same template multiple times. So you can see multiple reads, all of them covering one nucleotide, and you can get exactly how many of these reads are mutated. So you can get the allele frequency and know exactly the mutation rate or the allelic frequency. This is an example of KRAS mutation, G12V, 35G2T. CML, as you know, it's one of the myeloproliferative neoplasm. It's characterized by balanced translocation 922 between BCR and ABL1. And it creates this chimeric oncoprotein that increase proliferation, inhibit apoptosis. And it's not specific for CML, but it's one of the successful story for personalized medicine. Since we have the imatinib and other TKI, we start to have this personalized medicine. So we can give a treatment based on this fusion, molecular fusion. And it's a successful story, as you know, in hematology and in the oncology world. In CML, how we use molecular. So we need molecular at time of diagnosis, and we needed to monitor these patients. And most of these patients will eventually develop some form of resistance. So we need to detect this resistance as early as possible and interfere in the right time. At diagnosis, we usually do FISH, and we prefer to do FISH at the peripheral blood, but you can also do it in bone marrow. We do qBCR, quantitative BCR. This is to give the exact quantity. And as you know, quantitative BCR is more sensitive than FISH. It can detect very low quantity of BCR-ABL. And we can use NGS. NGS is a promising technique by using RNA sequencing. So you can detect the fusion also. And it depends on how you design your panel. So some fusions can be missed by FISH, can be cryptic. So it can be detected by quantitative BCR, and NGS is more accurate, but still BCR is more sensitive, and we will talk more about it. For monitoring, it's better to monitor these patients by quantitative BCR or digital droplet BCR. Both of these techniques are very sensitive, and they can detect very low level of BCR-ABL, and you can see like the deep molecular response by monitoring this BCR. Once there is suspicion for resistance, or if the patient progressed while on treatment, then using high sensitivity technique like NGS or Sanger, and NGS is more sensitive than Sanger to detect mutations. Around 95% of BCR-ABL will be detected by FISH. So FISH will detect most of these cases, but there is around 2.5% that are only positive by molecular technique, only by BCR or by NGS. It's just because some of them are very cryptic and a little bit difficult to detect by FISH. And again, CML is defined by BCR-ABL1, so we need it at time of diagnosis, and also we need it for monitoring. There are multiple breakpoints, as you are aware, in BCR and in ABL1, and this is why we have the major, minor, and the micro breakpoints with B210, B190, and B230. These based on the size, based on the weight, the molecular weight, so 220 kilodalton and 190 kilodalton. So basically you can have different arrangements, and most of cases will have the around 90% or more will have the either 210 or 190, and very rare cases will have the unusual fusions, and these are the ones that's difficult to detect by FISH. So again, at time of diagnosis, we need FISH. Monitoring, we need BCR or quantitative BCR. Once we suspect resistance, then sequencing is the best. I know that most of you know for CML monitoring, TKI is the gold standard for therapy. Stem cell transplant is usually not the first line. Definitely, we need to try some TKI, but once the patient develop major toxicity or progressed while in disease, then stem cell transplant is the last option. This is the criteria for cytogenetic response, for hematologic response, and this is the criteria for molecular response. Again, you can see that there is difference, and we usually go by log reduction. So if there is slight change in the quantity, it doesn't mean the patient is relapsing or progress, because there is some changes in the technique. But once there is one log reduction, like 10-fold change, then you know the patient is progressing. Several mechanisms for resistance to imatinib. The most common mechanism is kinase domain mutation. So if there is ABL1 kinase domain mutation, this is the most common way, and this is the thing that we need to test for it. There are other ways to get the resistance that's less common. Several mutations have been reported to be associated with resistance based on treatment like imatinib or the other TKI, and these mutations have different locations. And it's very critical to know that some mutations are resistant to one TKI, but they are sensitive to the other. So we can switch these patients to the other TKI, and some of them will show great response. On the other hand, some mutation like T315I are resistant to most of these, and you need to treat this patient differently. What's the indication for NGS testing or for sequencing in these patients? So we need sequencing either if there is failure or lack of optimal response to TKI. We need it in cases of advanced phase, like if the patient presented or developed accelerated phase, plastic phase, or pre-transplant mutation analysis may be helpful. So if the patient has decided to go for transplant, maybe it's better to test them by NGS or mutation analysis to detect the mutation, and later after transplant, they will be on the appropriate TKI. Also, if patient is in treatment-free remission, then you may want to test these patients, because if they develop resistance, then you may change their therapy, or maybe they are going to relapse later if they have some early mutations. In terms of other mutation, other than ABL1 mutation, there are several mutations. Maybe 25 to 30% of CML patients will have mutation in ASXL1, TET2, TET3, and MSH6 and others. And there are some mutations that will known to happen in a chronic phase. Most of these mutations are also part of CHIP mutation, like ASXL1, TET2, DNMT3A, TB53. On the other hand, there are some mutations that's known to be associated with more advanced phase, like RONX1, Acarose genes, or CDKN2A, RB1, GATA2, RAS mutations. They are also activating some of these kinase pathways, and these mutations are known to be associated with advanced phase. Mutational analysis by NGS is still in the early phases, so you don't see this done routinely, but it's coming. And there are several publications that shows that mutation analysis can provide early information about the biology and behavior of this neoplasm. Germline mutation in ASXL1 or PIM predicts imatinib failure. So you may test for these genes and find these abnormalities and give you an idea how this tumor is going to behave. In terms of analyzing the NGS report, it's very critical to know exactly what's in your panel, how the panel is designed, and what's the limit of detection. Because again, the sensitivity of the panel is very, very critical. You need to have a panel that's able to detect subclonal, like around 2% mutation, 3%. So that's very critical to know. And also very critical to know how much they are covering of the gene. Like, are they covering the entire ABL1 gene or entire kinase domain, or what's independent and what's limitation of the assay. That's very critical. Quality of the sample is also very critical. Variant classification is very critical because not all mutations are the same. So some mutations are pathogenic, known to change the function of protein, and some of the mutations are variant of unknown significant or benign mutation. Again, sensitivity is very, very critical for detecting ABL1 kinase domain, as this is different sensitivity. So if you are talking about Sanger sequence, the sensitivity is 20%. So you need to have at least 40% of the samples contain neoplastic cells. On the other hand, NGS, depending on how you design your NGS panel, can go very, very sensitive to 1% or even less than 1%. And now with developing some ultra deep sequencing, NGS has some promising data because it can be used even for MRD, because you sequence the same the same nucleotide at least 2,000 times. So you are doing multiple sequencing to detect even if there is any little change in terms of sequence. Also, NGS can detect compound mutations. So if there is multiple mutation in the same region can be detected, and also complex mutation, which is very tough to be detected by Sanger sequencing. The idea of having more sensitive technique is if you have early detection, then that will help you with early intervention. So if you wait until the resistance mutation become very prominent at 50% allelic frequency, then you miss the chance to start or change the therapy early. I will end my talk by brief take-home messages. First, cytogenetics and quantitative BCR is recommended at time of diagnosis, and there will be very helpful if you do it at time of diagnosis, so you can monitor these patients. Quantitative BCR and digital droplet BCR is the gold standard for monitoring. They are the best for MRD. In some way, they are best than NGS because they are very sensitive. ABL1 kinase mutation is responsible for resistance of TKI, either in chronic phase, accelerated, or even in plastic phase. NGS is a great technology, and doing the mutation analysis for ABL1 by NGS will provide higher sensitivity than Sanger sequencing. Sequencing in general, NGS or Sanger sequencing, it depends on the quality of sample. So the better the sample quality, the better the results, no matter what test you are using. NGS mutational profiling, other than ABL1 kinase mutation, show promising finding, and it will help in early risk stratification for CML patients. However, it's not well standardized yet, so it's not well. It's coming, but still, it's not the standard right now. Knowledge about the biology of the disease can allow earlier diagnosis and timely intervention. And thank you so much for your listening.
Thanks, Dr. Abdullah, for this excellent talk. And we'll keep the question at the end. We'll move to the third speaker today, Dr. Sulaf Kamfar. She's a consultant adult hematology and stem cell transplant in King Faisal Specialist Hospital, Dammam. She's a program director of adult hematology and stem cell transplant. She's an assistant professor in internal medicine in Imam Abdurrahman bin Faisal University. She finished her Saudi fellowship in adult hematology and stem cell transplant in 2015. Dr. Kamfar finished her fellowship in acute leukemia at Prince Margaret Center at University of Toronto in 2016. She did her allogenic stem cell transplant fellowship at Prince Margaret Center in 2017. Dr. Kamfar, she had many publications. And Dr. Kamfar, today she will talk about the treatment-free remission. Dr. Kamfar, the stage for you.
Thank you, Dr. Ammar, for this kind introduction. I would like also to thank the organizer for inviting me to speak today in the CML webinar. My talk is basically a continuation of Dr. Kim and Dr. Suwaidan talk about chronic myeloid leukemia. These are my objectives. I'll discuss about the goals of CML therapy, the treatment-free remission definition and rationale and the data behind it, the recommendation guidelines, post-discontinuation surveillance and predictor of relapse, and finally, the management of molecular relapse and the second trial. So what are the current goals of therapy? We discussed already the therapy of chronic myeloid leukemia, and we know that the goals of therapy has changed over time since the introduction of imatinib in early 2001. Initially, our goal was mainly to prolong survival and delay disease progression, but with the further knowledge of the disease and advent of new molecular testing and cytogenetic testing, the achievement of cytogenetic remission and molecular remission became our goal. And currently, we also aim to achieve a deeper molecular response that can lead to treatment-free remission. So the guidelines had changed over time, as explained previously by Dr. Kim. And I just want to note also that the NCCN guidelines has incorporated now the goal of TFR in the milestone goal of therapy, where you can see here in the light green, the goal changes from MMR into deep molecular response if your goal is treatment-free remission. So what is TFR? We do know that many patients achieve a major molecular response in the first 6 to 12 months. And a large fraction of these patients will have a further reduction in the level of measurable residual disease with continual TKI therapy. This will lead to a progressively deeper molecular response. These progressive slow recruitment of patients to MR 4.5 raises the possibility that with very long treatment, the level of measurable residual disease can continue to fall as long as effective therapy is continued. And these patients who are in deep molecular response are assumed to have a more stable remission with lower probability of progression. So until recently, the recommendation was to continue the tyrosine kinase treatment permanently outside the clinical trial, but now treatment-free remission is in the picture. Why would we stop the tyrosine kinase inhibitor? There's many reasons to suggest stopping the treatment in patients with chronic myeloid leukemia. Most importantly are the adverse drug reactions to tyrosine kinase inhibitors, either first or second generation. The interaction between these medication and other medication if the patient has multiple comorbidities. There are data also that showed that prolonged therapy may impair the quality of life of patients. So stopping it might be an aim for this patient population. Family planning also is one of the most important causes of stopping medication, especially in our patient population, where the median age is much, much lower than in other countries, where patients can present in the early 20s. And family planning is one of the first questions when we start the tyrosine kinase inhibitor. Patient request and long-term adherence are also causes for stopping the therapy. And finally, there is marked impact on the healthcare cost if you stop tyrosine kinase inhibitor, especially if they use second generation TKI. So the concept of treatment-free remission is not new. Actually, it was also considered when they used interferon for treatment of CML. But the first pilot study was in 2007 when they tried to discontinue imatinib with strict entry criteria in a 12 patient, and 6 of them were successful after a median follow-up of 18 months. And this inspired the first STOP trial with discontinuation of imatinib in patients with chronic myeloid leukemia who have maintained complete molecular remission, the STOP imatinib trial. They enrolled 100 patients between 2007 and 2009. And the criteria of stopping imatinib was solely undetectable molecular residual disease. Please remember that this study was in early 2007 and the definition of undetectable molecular residual disease was there. But currently we use the term of deep molecular response. The relapse triggering retreatment was defined by the confirmed BCR-ABL positivity or any loss of major molecular response. So around 61% of these patients relapsed and 41 maintained a TFR of around 12 months. And a conclusion of the study was that imatinib can be safely discontinued in patients with chronic with CMR for at least 2-year duration. The long-term follow-up of this study in 2017 with a median molecular follow-up treatment of 77 months, the molecular recurrence-free survival was around 43% at 60 months and 38% of around 48 months. And this also led to the same conclusion that imatinib can be safely discontinued in patients with a sustained deep molecular response with no late molecular relapses. The design of the majority of prospective longitudinal study was inspired by the Stop Imatinib trial in defining the minimal criteria for total duration of TKI exposure, the deep molecular response, and the molecular endpoint of defining failure. This graph showed you the number of studies concerning TFR that are even ongoing. You can see here the median duration of TKI prior to attempting stopping the TKI therapy, either first or second generation. And you can see here the TFR ranges from between the 40 to 60% in all the studies. If we put them in a table view, you can see that we have many trials concerning TFR with first-line imatinib or second-generation TKI. They have a variable TFR rate of between 40 to 60%, and they actually differ also in the median duration of DMR or the median duration of tyrosine kinase inhibitor. So the question comes, is it better to start a first-generation or a second-generation TKI? We do know that second-generation TKI induce faster and deeper response than imatinib, and this will increase the number of patients who will actually reach a deep molecular response that can put the patient criteria for stopping tyrosine kinase inhibitor. But is this enough to increase the rate of treatment-free remission? There is several studies that looked at second generation either as a first line or a second line. I have this table summarizes some of the these study in the nilotinib and the dasatinib. And as you can see that the TFR rate is similar to these of using imatinib or imatinib TFR rate. But if we can concentrate to the evaluating nilotinib freedom trial, we can see that they have the same TFR rate, but with the shorter median duration of stable DMR and a median duration of TKI. So it showed actually that achieved this degree of TFR only after a median of 3.5 years of TKI exposure, and this was impressive in a form of second generation TKI. And the other trial did not show any difference compared to imatinib. Most of these trials actually are non-randomized except of the Hoven trial, which has only a small number of patients. But the largest so far trial is the Euroski trial, enrolling more than 750 patients. It is a prospective non-randomized trial, multi-center, who included patients with chronic myeloid leukemia in chronic phase who received any tyrosine kinase inhibitor for 3 years with a confirmed deep molecular response for at least 1 year. Their primary endpoint was molecular relapse-free survival with a secondary endpoint that looked at the prognostic analysis of factor and the cost impact of stopping TKI therapy. So it showed that the TFR rate is almost 61% at 6 months and around 50% at 24 months, similar to the previous study. But the secondary endpoint, interestingly, showed that TKI discontinuation was associated with a substantial cost of saving around 22 million euros. And the other endpoint showed that the prognostic analysis of these patients showed that the longer treatment duration and the longer deep molecular responses duration were the main factors that can affect your TFR rate. There are other predictive factors of relapse. The treatment of duration and longer deep molecular response are the main ones. And if we can see, this was also explained by Dr. Kim, I'll just review it very fast, that the patient, for example, if your patient was on a certain TKI with an MR4 at duration of 4 years, they will have a TFR rate of around 50%. This will markedly increase each year. For example, by 6 years, he will increase the TFR rate to 60%, which is better and impressive. So for a successful treatment-free remission, we need both patient factors and laboratory factors. You need a careful patient selection, and you need a good, reliable lab that has rapid BCR ABL results. So these are the NCCN guidelines for treatment discontinuation. They are mainly for patients more than 18 years. Patient need to be in chronic phase with no history of accelerated or blast phase. They have to be on approved TKI therapy with prior evidence of a quantifiable BCR-ABL transcript. They should have a stable molecular response of at least 2 years. Already Dr. Kim discussed that the longer duration is better, but these are the NCCN recommendation, and they recommended monitoring, as we will see just in a minute. The ELN, as just explained, has the same thing or recommendation as per the NCCN. The main difference is in the duration of the TKI. So it is minimal if your duration of TKI therapy is almost 5 years, and 4 years if it is second generation TKI, or the duration of DMR, MR4 or better is more than 2 years. Optimal, of course, they will have longer duration either of DMR or TKI therapy. Now for monitoring, it's very important for the timely PCR result for the safety for the patients who undergo a TFR attempt, because most patients failing a TFR attempt do so as an exponential increase in BCR-ABL, raising around 1 log per month. So all the guidelines, the NCCN, ELN, and ISMO have the same recommendation to do monthly BCR-ABL for the first 6 months of the treatment-free remission trial, then every 2 months for months 7 to 12, and finally quarterly thereafter. An interesting complication that has shown in patients who tried to stop the therapy is the TKI withdrawal syndrome. So cases of musculoskeletal pain and itching have been reported after patient stopped taking tyrosine kinase inhibitor. And this was initially reported in the first 50 patients in Sweden who were included in the EuroSki study. Around 30% reported musculoskeletal pain evolving gradually from 1 to 6 weeks after TKI discontinuation. And some of them had a localized pain in various parts of the body, or had some pain that resembles polymyalgia rheumatica. So in the patient from the Stop Imatinib trial and the EuroSki, they were systematically analyzed, and it shown that only almost 23% of these patients experience tyrosine kinase withdrawal syndrome. The predisposing factor were mainly medical history, osteoarticular pain, disease, or the duration of therapy prior to discontinuation trial. It's usually self-limiting. It can persist for months. If the patient requires, you can prescribe some analgesia or non-steroidal anti-inflammatory drug. In very severe cases, you can start some steroids in these patient population. So molecular relapse in a patient with a trial of TFR equals molecular recurrence of CML. And there have been discordances in the molecular relapse definition across trials, as you can see in the retreatment criteria for this patient population. So probably this difference is mainly because of various levels of deep molecular responses, inter or intra-laboratory variation of the PCR assay sensitivity, and also the lack of initial consensus of the lowest amount of residual disease compatible with TFR. So in the Stop Imatinib trial and the Twister trial, the relapse was defined as the detection of a BCR-ABL transcript in 2 consecutive samples showing a rise between the 2, or MMR loss at any single sample. But they have noticed that in patients who lost in 2 consecutive samples, the reluctance of the patient to rapidly start therapy led to the observation of continuous or intermittent detection of BCR-ABL transcript. And this did not automatically predict CML relapse. In addition to that, patients who restarted imatinib did regain deep molecular response regardless of their level at that time. So the definition of molecular relapse became the loss of MMR in the following studies, rather than the loss of deep molecular response. It's very important to note that almost all patients, even those who lost MMR, were sensitive to TKI re-challenge, as MMR or deep molecular response were rapidly regained. For example, in the EuroSki, the MMR was regained after a median of 3 months, and the Stop second generation TKI, it was regained after a median time of 2 months. So from a practical point of view, Resume TKI therapy at an efficient dose no later than 1 month after a molecular relapse. Monitor your patient transcript monthly until achievement of MMR and then every 3 months. Bone marrow and karyotype and screening for a mutation generally not recommended, only if the patient did not achieve MMR timely. And in case of a resistance to TKI, the reintroduction of second generation or another TKI is warranted. So before concluding, I'll just ask you, will you consider attempting a second discontinuation trial after regaining deep molecular remission again? So in the many discontinuation studies, there was no CML-related death. And the patient who failed to remain treatment-free due to outgrowth of the leukemic groin were sensitive to a TKI re-challenge. So in the re-stop imatinib study, patients who failed the first TFR and returned to the state of MR 4.5 on retreatment has almost a 35% rate of a second TFR at 3 years, and up to 72 at 2 years in the subgroup that re-established a deep molecular response without 3 months of the reinstatement of TKI therapy. No progression towards advanced stage CML and no efficacy issues about TKI reintroduction. So the conclusion of the study was that a second TKI discontinuation attempt is safe and a first failed attempt does not preclude second successful attempt. And I think Dr. Kim also had an oral presentation at ASH looking at the similar second TFR attempt, showing similar conclusion. So in summary, patients with CML who achieved a deep molecular response have a good molecular relapse-free survival, and these patients should be considered for TKI discontinuation. Discontinuation of first generation or subsequent second generation TKI yields to promising TFR rates without any safety concerns. About 40 to 60% of the patient with long-lasting deep molecular response on tyrosine kinase therapy are likely to remain prolonged TFR after treatment discontinuation. And the duration of DMR is the most predictive factor of the TFR. Stopping treatment can spare some patients from treatment-induced side effects and reduced health cost. And patients who failed to remain treatment-free were sensitive to a re-challenge with the TKI with no CML-related death. A second discontinuation of TKI therapy is possible and should be reserved for selected patients. And we still need data from a larger study. Thank you.
Thank you, Dr. Salah, for this comprehensive talk about the TFR, and thanks for all speakers for this comprehensive talk about chronic myeloid leukemia. And we'll leave the floor now for the audience for the question and answer. Okay, I will take the opportunity to ask the first question for Dr. Kim. Dr. Kim, what to do for patient who achieve complete cytogenetic response, but his BCR-ABL always not in major molecular response. So for this kind of patient, shall we continue with the same TKI or we'll shift to another TKI?
That's a really good question. So as you can see, ELN 2020 recommendation, it mentioned that if a patient failed to achieve MMR more than 36 to 48 months, then you can consider the switch of the medication. However, now you are now arguing that there are some patients who achieved the CCYR, which is equivalent to a 2-log reduction, but never achieved the MMR. In that case, it really depends on what is their goal of their CML treatment. If their goal of their CML treatment is, for example, TFR, you better to switch. You better to switch to something else. But for example, if your patient is like 80 years old now, you may just consider the survival advantage as your treatment goal of CML therapy, and patient is now tolerable to that medication, and patient has a multiple other medication. You have to consider the other potential drug-drug interaction. When you switch it over from your current medication to something else, in that case, I will not try to be more aggressive. I will just probably continue your current treatment. Patient achieved the CCYR. I know it is not enough. However, considering all that kind of characteristic of the patient, comorbidity, et cetera, I will not be that much aggressive. But it really depends on what is your goal of CML therapy. I hope that is the answer for your question.
Thank you, Dr. Thank you, Dr. Kim. There is a question from the audience. Patient in chronic myeloid leukemia with blast crisis on major molecular response, post chemotherapy and TKI, but the patient is not feasible for transplant.
Yeah, we see that kind of case all the time, especially in an elderly population. Not only the CML patient, maybe the Philadelphia positive ALL case, and patient achieved some good molecular response, and you try to maintain the TKI therapy after achieving the CR, but now the issue is that then how long do you have to continue? Probably there's no data that you can stop the TKI therapy and TFR attempt in that scenario, because as you can see, for TKI discontinuation attempt, the patient who has a past history of advanced disease such as a blastic crisis or accelerated phase, they are contraindicated for TKI discontinuation. So stopping the TKI therapy is not a good idea. However, then you need to be very careful about which TKI therapy you would like to go ahead. I think that tolerability is the key issue in that setting. So you have to choose a certain drug which could be for which patient can maintain the medication without having any kind of tolerability issues.
Okay, thank you, Dr. Kim. There is another question from the audience to Dr. Kamfar. You said we have more younger patient at diagnosis in clinical practice. Is it justified to go for the second generation TKI if the goal is TFR?
Yes, actually, we noticed in our center that the median age of CML is really young. We have young patients, both male and females, in the early 20s, late teens even. Actually, all TKIs are approved as first line, and in our center, in patients who are younger and the TFR is our goal of therapy, we start with second generation from the beginning. After counseling with the patient, discussion about the side effects and our goal of therapy, we start second generation TKI for this patient population.
Okay, thank you, Dr. Sulaf. There is another question to you. I think Dr. Dennis is typing the answer. How to prevent TKI withdrawal syndrome?
Oh, so how to prevent the TKI withdrawal syndrome? There's no way, and it's very difficult to predict it. However, some patient who had a past history of musculoskeletal discomfort or pain before having a diagnosis of CML and treated with the TKI therapy, and they experienced the complete resolution of that kind of musculoskeletal discomfort, they are kind of a high-risk group of the patient going to develop TKI withdrawal syndrome. So it confirmed that the TKI drug is kind of it has anti-inflammatory activity. So while they are on an imatinib treatment, because it is also working as an anti-inflammatory agent, they experience the resolution of that kind of inflammation in their body. However, after starting the TKI therapy, then they flare their musculoskeletal symptom again after the TKI discontinuation. In that case, probably you may have to use NSAID to treat the that kind of musculoskeletal discomfort after the TKI discontinuation.
Okay, Dr. Kim. There's a question also from the audience. With the current direction of therapy of CML, some patients who are intolerant of TKI, they may require interruption of treatment and dose reduction. How this will affect our goal to achieving DMR in treating such patients?
Is it a question to me or to Solaf?
I think this question to you, Dr. Kim.
So can you repeat the question one more time?
Yeah.
Yeah.
The question is, with the current direction of therapy of CML, some patients who are intolerant of TKI, they may require interruption of treatment and dose reduction. How this will affect our goal for achieving DMR in treating such patients?
So that's a really good question. So now you experience a lot of dose interruption during the TKI treatment for your CML therapy. And your goal is for them to achieve a deeper molecular response before you consider the TKI discontinuation as your ultimate goal of their CML therapy. So in that setting, probably make them to continue to take the pill without having any kind of tolerability issue. That is your key. And because of that, they need a little bit of they need a little bit of time to adjust to your current treatment. For that reason, you interrupt the medication from time to time. That is not a big issue. However, interrupting the medication quite a long period of time, that will become a significant issue because it is also associated with the compliance. But based on if a patient maintains certain response and they achieve some molecular milestone, then I do not think that's a big issue for them to try to stop their medication just to have more time to adjust to the medication. That's not a big issue.
Okay, thank you, Dr. Kim. My question to Dr. Swedan, you mentioned that in the diagnosis of CML, we need to do FISH. So is it for any patient you advise to do FISH with conventional cytogenetic, or you can subdivide your patient?
So at time of diagnosis, FISH is preferred with quantitative BCR. The purpose of doing FISH is a good technique that can detect up to 95%. And we do BCR just in case of, since we are going to use it for monitoring. So if you have a baseline at time of diagnosis, it's easy for you later for monitoring. FISH is very sensitive technique. You can see exactly where is the probe and see where is the tumor cells or the neoplastic cells. So it's very sensitive. It will detect most of these cases. Again, if FISH can detect up to 5%, BCR can detect some cases depending because there is no BCR that's designed to detect all type of fusions. Even for rare fusions, it's difficult to design the probe to detect everything. So if you do both, then you will detect most of the cases, and for monitoring, it will be the quantitative BCR.
Okay, thank you, Dr. Abdullah. There is another question from the audience. I think this question to Dr. Solaf. This trial from UK suggested that having a dose of TKI for 1 year before TKI discontinuation, increasing the TFR rates. Does the panel recommend this approach?
Yeah, this is a very excellent question. So I looked at the data of the Destiny trial, and actually it's a good idea to decrease the dose of TKI to that. But the other recommendation and the other guidelines did not recommend stopping or tapering down the dose before attempting TFR. So in our practice, we stopped the TKI directly without decreasing the dose or changing it. I'm not sure, Dr. Kim, if you had an experience in that.
So once you read the Destiny trial, you just have to be a little bit careful. They reduced the dose to a half. So for example, in the patient who was taking the imatinib 400, then you reduce it down to 200 and maintain it for 1 additional year. And then if they continue to have an undetectable transcriptor level, and then you recommend to stop them. However, any patient who lost their molecular response in first 1 year, they have never achieved the TFR. So probably it gives a lot of selection bias. So you have to be very careful to adopt that kind of approach in your clinical practice. I think that it is also consistent in the ELN and the NCCN recommendation. You just have to be very careful to adopt that kind of idea into your clinical practice.
Okay. Another question from the audience. What sort of TFR success rate are you seeing in your practice? I think for both Dr. Kim and Dr. Sulaf.
So let me just illustrate my situation here in Canada, especially in Ontario. In Ontario, we do not have access to monthly test. So because of this, I can't generalize the approach of the TFR. I only try to use TFR-based practice in my patient who is suffering from the lots of drug-related side effects. For some reason, but their TFR rate seems to be pretty good. It is more than what I have expected, more than, I will say, more than 60%, 70%. Even they had been treated with less treatment duration with the TKI therapy, their TFR rate seems to be at least at around 60%. And I also have another group of the patient who failed the first attempt and then tried to be treated with the dasatinib as a second line. And then we tried a second attempt of TKI discontinuation and they failed. However, then we do not follow them anymore under the clinical trial. However, in my practice, I have at least 3 or 4 patients, and in some reason they ended up to develop certain pleural effusion, and then now they maintained at least the MMR without requiring any active TKI therapy. So there is something that it is doable to achieve second or third TFR with a multiple attempt of TKI discontinuation. But the problem is that we cannot generalize. We cannot generalize that kind of approach to our practice. You have to be a little careful about that.
So in our center, actually, we started the TFR trials for the last 3 years. Unfortunately, COVID came and limited the access of patients to come monthly for testing. So far, we have almost 11 patients. 3 of them actually relapsed, but the rest of them until now, with a median follow-up probably of 7 months or 8 months, they're still in TFR. So I think the results are actually very good and impressive.
Okay. Thank you, Dr. Sulaf. Thank you, Dr. Kim. There is another question from the audience. If the TFR attempt is bound to fail, is it likely to fail within the first 3 months?
Can you repeat one more time?
Yeah. If the TFR attempt is bound to fail, is it likely to fail within the first 3 months?
So usually if they are going to lose their molecular response after the TKI discontinuation, they will lose their molecular response within first 4 months within 90% of the case. So 90% of the case, they will lose their molecular response in first 3 to 4 months. So probably maybe in first 3 months or 4 months, you have to monitor their PCR test monthly. But maybe after that, their risk of losing their molecular response is pretty low, around 10%. Still, there is a case who lose their molecular response up to, based on my experience, up to 18 months. But I haven't seen any case who lose their molecular response after that, 18 months after the discontinuation.
Okay, thank you.
If you can correct me also, the continuation trials or the follow-up trials of the evaluating nilotinib trial and I think Euroski trial showed that the late relapses are rare. They're less than 10% probably. And as you said, it's mainly in the first few months that the patient will relapse.
Yeah, especially in first 1 year, especially in first 6 months, but especially in first 4 months.
Okay. There is one question. Chronic myeloid leukemia in pregnant, imatinib can be used in some report. So is it safe to use imatinib in pregnant?
During pregnancy?
Yes.
It's different between the male patient versus the female patient. In case of male patient, probably it would be okay for them to take the imatinib. However, for female patient, because of the neural tube defect issues, still there will be a little bit of concern. Probably in that case, you better to go ahead with maybe other, nilotinib or other second generation TKIs. But dasatinib does have also some other kinds of case report. So, but we try to use the concept of TFR for the pregnancy in female patient first, And then if it doesn't work, then we can try interferon. But the problem with interferon is that now the company who was manufacturing the interferon, they are now terminating the manufacturing of the interferon. Then it will make a little bit of issue.
Yeah. Any more question from the audience?
I have a quick question to Dr. Al-Suwaidan.
Okay.
So now you just mentioned about your NGS, but you didn't specify which sample is prepared between the RNA sample versus the DNA sample. So I wonder now, in terms of there is a little bit of debate about which sample is better for NGS, especially in terms of CML area between the RNA versus the DNA. If you want to detect like ASXL1 mutation or LUNGS1 mutation, etc., most of that kind of mutation detection is based on the DNA in other myeloid neoplasm. But what would be your thought about that? Do you prefer to use DNA sample for LUNGS1 or ASXL1 or TP53 mutation detection, or do you don't mind to use RNA sample? And if you have that kind of experience, I wonder what will be the correlation between the result from the RNA sample versus the DNA sample?
Yeah, thank you so much. It's an interesting question, and there is no perfect answer. I have heard several point of view from different people, but for us, like, we go by the gold standard. So for fusion testing, like if you are testing about BCR-ABL, the fusion itself, we prefer the RNA. And usually RNA is better because you can have different breakpoints. So if you design your primers to bind at the both ends, like for forward and reverse, so you can cover any type of fusions, even for unusual breakpoints, then they will be aligned to the reference, and you can detect the fusion. So for fusion, even DNA can be used, but RNA is even better. When it comes to mutational analysis, again, the DNA is more stable, and if you are talking about mutation that happen within the exon, within the reading sequence, then definitely you can detect this by doing RNA or by doing DNA, because both of them will have the complete exonic sequence. If you are talking about mutation that can happen in splice side, like even with TP53 or with ASXL1, then having DNA analysis that cover like at least 10 base pair of either end, we call it the intervening sequences, the splicing donor and acceptor areas, then it's better to have the DNA sequence covering the splice, because you will lose this splicing site mutation if you do only RNA sequence. So there is no perfect answer. We go mainly by DNA because it's stable, it's well characterized, and it can be stored for a long time. And but again, it depends on type of mutation that you are looking for.
Thank you for your insightful feedback.
Thank you. Any more questions from the audience? Okay, I didn't see any more question. If you allow me, I will ask the last question. When can if I have a patient with chronic phase CML, when can I send him to allo stem cell transplant?
So allo transplant for consult, or you really want the patient to have an allo transplant? So yeah, probably if you are now thinking of sending the patient for consult, then if they failed more than 2 lines of TKI therapy, then you need to start HLA search, right? You need to try to find it out if the patient doesn't have a donor. And then you can send the patient for allo transplant just for them to have this is also there is a potential treatment option called the allo transplant for your CML therapy, and they need to know about that. There is a little bit of legal aspect about that. However, in case of chronic phase CML, I will let them to have a discussion in our BMT team, but I will be a little bit reluctant to go ahead push the patient into that direction unless they failed more than 2 to 3 lines, additional 1 or 2 more lines of TKI therapy. However, if they have a blastic crisis CML and they just convert it to a chronic phase CML2, but in that case, I will push them to go ahead to allo transplant. Accelerated phase, it's a little bit difficult because some accelerated phase patients, they are super sensitive to TKI therapy and they are really, they are maintaining the optimal response very nicely. In that case, probably based on the current WHO classification system, they are categorized into an accelerated phase, but their disease may not be in that advanced disease. Their disease will be still in chronic phase. However, if they already failed the first-line TKI therapy, then they should go ahead to allo transplant. That is my suggestion.
Okay, thank you, Dr. Kim. Any more questions from the audience? Okay, so there is no more question. I would like to thank all speakers for this comprehensive talk about the chronic myeloid leukemia and comprehensive review. And also I would like to thank the Saudi Society of Blood Disorder for this organization. And also will thank the Novartis company for sponsoring for this activity. And I think we finish our webinar and have you hope for you a nice day.
Have a great evening.
Yeah, thank you so much.
Thank you.
Thank you.
Thank you so much.
Thank you.
Bye.
Bye.